We will begin our discussion of brain disorders by focusing first with the acute disorders of brain function. Our discussion of acute disorders will begin with discussing the mechanisms of brain injury, which can, of course, be mechanical trauma. One you should be familiar with at this point, though, ischemia and resulting cellular energy failure, reperfusion injury, excitotoxins, we'll define those in a little bit. Edema, of course, can cause problems within the central nervous system. Vascular failure, and finally, as a result of the injury, induced apoptosis. You also need to be aware of the fact that there are two categories of a brain injury. The first one is referred to as primary injury, and this is what occurs immediately at the onset of injury. So if you were in a car accident or something, it's the head trauma. It includes obviously impacted tissues then. And cells are not receiving, or I should say cells that aren't receiving oxygen as a result of a stroke. Secondary injury, this is further injury that occurs subsequent to the primary injury. So we may see delayed cell death as a result of apoptosis, but also perhaps of reduced ATP levels. The secondary injury is really one of the primary reasons for the high rates of morbidity and mortality that there are in brain injury. And so you can imagine that there's a lot of research going on how to prevent the secondary injury from occurring. So we'll start off our discussion with a discussion of ischemia, something you already know about. So it's a contributing factor in most forms of acute brain injury, as it says. And it could be primary, which is the result of a stroke, or secondary, in which case compression can occur, or abnormal autoregulation, maybe a vasospasm. But eventually what's going to happen is decreased oxygen to the tissues, and of course that's known as hypoxia. And ischemia results in immediate neurological dysfunction because the neurons need to generate ATP just about constantly. Ischemia then also will set the stage for secondary injury by oxygen-free radicals, excitatory amino acids, and inflammatory cells as a result of the primary injury. What exactly do we mean by cellular energy failure? Well, you may recall from our discussion of diabetes that even though the liver and muscle cells required insulin for get the glucose into the cells, the nerve cells do not, because nerve cells function predominantly, almost exclusively on glucose, and this is because they have very high ATP requirements. However, they don't have a lot of stores of it, and they rapidly run out of ATP if oxygen becomes limiting, if you start to run low on oxygen. So what happens? What we learned in the first week, a loss of ATP leads to dysfunction of, number one, sodium-potassium pump, eventually leading to an influx of calcium into the cell. And it's the calcium overload that leads to activation of various cellular cascades that cause irreversible membrane damage. So once again, we're reviewing what we learned in the first week of class. In fact, this flow chart again is summarizing one of the flow charts I gave you. As a result of ischemia, the cell hypoxia, the mitochondrial failure, the decrease in ATP, decrease in calcium pumping, and of course it lead to a calcium overload and reperfusion injury. But notice the little thing that I put on the bottom there, of course, that within 5 to 10 minutes of complete occlusion, irreversible brain damage can occur in humans. So you can see how important blood flow to the brain truly is. Now, what are these excitatory amino acids? Well, glutamate is the number one. It's referred to as an excitatory amino acid, which it helps with learning and memory, but overstimulation by glutamate leads to cell injury. And of course, what can happen is then you get too much calcium into the cell. So glutamate, it can also be thought of as an excitotoxin. When it binds to certain receptors, particularly these alpha amino 3 hydroxy 5 methyl isoxyl propionic acid. Tried to say that real fast. Anyway, when it binds to A and pH channels, sodium channels open and the membrane depolarizes. That gives you an excitatory response. The depolarization then has a tendency to remove these ions that then block another receptor, the NMDA receptor. So now glutamate can bind that, and that's what lets calcium into the cell. And in the absence of glutamate uptake mechanisms, in other words, pumping them, remember the calcium pumps that pump them either into the sarcoplasm, the endoplasmic reticulum, or out of the cell. Remember, they require ATP. The glutamate accumulates and lets in too much calcium. This is just summarized in this picture where you can see the two different receptors and how binding to one leads to the ability of binding to the other one that then causes the increase of calcium into the neuron. Reperfusion injury is also a problem in the brain. It occurs following, of course, restoration of the blood flow to any area that experienced the ischemia. Same mechanisms that we talked about in cardiovascular system occur within the central nervous system. So you get the oxygen-free radicals formed, and these are damaging the same cellular structures that we learned about again back in the first week of class. And this is just a picture from one of the earlier chapters on cellular injury. Well, of course, there are immune mechanisms of brain injury as well. They are not as well understood as in other systems of the body. We do know that as a result of injury and then inflammation, the blood-brain barrier actually becomes compromised, and this will happen with the ischemia and injury to the endothelium cells directly. But in addition, as a result of the ensuing inflammatory response, you get the release of our usual suspects, as I like to say, IL-1, IL-6, and tumor necrosis factor alpha. And when they increase in the brain, what happens, the capillary and when that happens, well, the capillary endothelial cells are injured by this. Mostly they're activated, they roll up, and this helps to promote the inflammation, the brain edema. Attracts neutrophils that secrete more cytokines, and then, of course, release enzymes that can damage the tissue. And the neutrophils may generate more radicals and promote vascular obstruction because they themselves can aggregate as well as the platelets. But this is, people are arguing this one, so we don't know this one for sure, but it may contribute. Abnormal autoregulation can also occur in the brain. Now, autoregulation in the brain, just like in other tissues, of course, is to control the blood pressure within the brain to a certain level, between 50 and 150 millimeters of mercury. Greater than 150, then you start to cause vascular damage through compression and, of course, brain edema. If you get less than 50, however, this predisposes us to ischemia because you're not getting good blood flow. Cerebral vessels will dilate when the arterial blood pressure decreases or when the brain metabolism increases to try to increase the amount of blood to the area. However, things such as thrombi, emboli, vasospasm, and neutrophil aggregation can prevent this vasodilation, contributing to the formation of ischemia. Additionally, vascular injury may impair the vasoconstriction and lead to hyperperfusion and edema. So without a good autoregulation, you can either get too much ischemia or too much blood and edema resulting. Cerebral blood vessels, if you recall, we talked about this earlier, will respond to changes in pH, concentration of CO2, and the arterial pressure of oxygen as well. In fact, as the pH CO2 decreases, the cerebral vessels will actually constrict. And as it increases, they will dilate. Now, remember, if you have too much CO2, it suggests that you don't have enough oxygen present, and so the dilation of the vessels is to improve flow and oxygen to the neurons. It's a rapid response to the changes in the CO2, and this can increase cerebral blood flow significantly, especially when respiratory compromise leads to hypercapnia. Hyperventilation, however, will result in very fast vasoconstriction and a decrease in the intracranial pressure, or ICP. In fact, hyperventilation has been given to patients with an elevated ICP, but lately they realized that this seems to reduce the blood flow too much and can actually trigger additional ischemia. Studies have shown that cerebral oxygen demand correlates very well with neuronal activity and can vary from region to region depending on what you are doing or what your patient is doing. Excessive catecholamines or excitatory amino acids can actually increase this metabolism and then contribute to ischemia because it's increasing oxygen demand. Seizure activity really increases oxygen demand, and it's increasing the neuronal metabolism and can actually precipitate an ischemic situation. So it's very important under those circumstances to reduce the excitatory neurotransmitters either through hyperthermia, reduce the temperature, rest, pain control. All of that can be very beneficial to preventing ischemia in someone with seizures. Hypothermia, it's a strategy to basically reduce the brain metabolism and protect it from ischemic injury. We know that this happens from people who have been immersed in water with low temperatures. It seems to inhibit perhaps glutamate release and IL-1 and significantly reduces the metabolic rate and helps to suppress the inflammation. However, we still need to do some studies for properly using it under different circumstances. Now, of course, one of the things that you have to be very careful with brain injury is an increase in the intracranial pressure, or ICP. In fact, this is a common cause of morbidity and mortality for people who have sustained a brain injury. Normally, the skull pressure is really pretty low, between 0 to 15 millimeters of mercury. And believe it or not, there are mechanisms to maintain a pressure volume equilibrium within the skull. So, and this is between the blood, the brain tissue, and the cerebral spinal fluid. So normally, if you increase the volume of one, then you can compensate by decreasing the volume in another. And therefore, the volume remains unchanged, and so does the pressure. Well, in order for that to work, the brain has to have a certain amount of compliance, which of course is defined as the brain's ability to accommodate changes in intracranial volume without changing the ICP. Now, the brain is both plastic, meaning it can be deformed, and elastic and resist this deformation, but it's limited because it's stuck within this rigid skull. So while small increases in the intracranial pressure can be absorbed, moderate ones will lead to really high increases in ICP rather rapidly. Now, however, cerebral blood vessels can reduce the volume by vasoconstriction, and some of the cerebral spinal fluid could be shunted into the subarachnoid space or the venous system to reduce the volume. But that's not a lot that they can do with. Both of those can't really reduce volume that much. So when you exceed the compensation, the ICP is going to rise. The brain tissue itself, or the brain parenchyma, has little ability to reduce its volume or compensate. All right, so it can't do much. And of course, when you lose what compliance you have with the other two mechanisms, the ICP rises very quickly and can be life-threatening. Well, this does happen a little bit with an increase in ICP transiently when people are sneezing or coughing and this sort of thing, but it quickly returns to normal. However, the real problem with an increase in ICP is that this leads to swelling and compression of the blood vessels. That gives you ischemia. And then the next thing you could do is herniation. And this is a problem because it shifts the brain, and this is what's really occurring with the herniation. And of course, that can damage tissue as well as induce more ischemic injury. And this just shows you examples of herniations that can occur as a result of an increase in ICP, and you can see that they are occurring at different areas. This figure demonstrates that within a certain range of volume, you have good compliance, but once you get a little bit above that, very quickly the pressure will rise, and there's nothing that can be done by the other compensatory mechanisms within the brain. So what causes ischemia within the brain? Well, stroke is number one, but trauma and tumors can also do the same thing. You have an increase in the brain tissue, follows diseases that cause also cerebral edema, so that can lead to ischemia. And the accumulation of fluid then occurs as a result of that, both in interstitial and intracellular spaces, but it's increasing volume, which can then lead to compression of blood vessels. Vasogenic edema can also occur. This is interstitial edema. Again, it's secondary to an increase in capillary pressure, or it's damage to the capillaries themselves. So in this case, the vasogenic edema is usually localized to an area where the blood-brain barrier has been disrupted, and of course you get unilateral swelling, shifting, of course, and compression. This tends to occur slowly and occur days after a primary injury. Other causes for ischemia within the brain: cytotoxic edema. This is where intracellular edema is occurring. And again, because of ischemia, that leads to cellular energy failure. So the sodium-potassium pump fails, sodium and water comes in, and this cytotoxic edema has a tendency to occur in cases of global edema, in which oxygenation to the entire brain has decreased. Really not a good thing. And then vasogenic and cytotoxic edema can occur together, and again will result in compressing blood vessels, and again that leads to additional ischemia. However, the brain will try to compensate for some of this increase in volume by clearing the edema through into the cerebrospinal fluid, which can then flow out. Space-occupying lesions can also lead to ischemia. These include things such as tumors, hematomas, and abscesses. They can increase the ICP, usually because they're on one side, so they're unilateral, and then they lead again to the compression and herniation. And this can show you pictures here where you've got herniation on the left, where things are being compressed to one side, and then of course the very evident tumor on the right. Additionally, you can have an excessive accumulation of the cerebrospinal fluid. This is referred to as hydrocephalus. This will lead to an increase in intracranial pressure, but here what's enlarging are the ventricles, and then they compress the cerebral brain structures. And this picture I think is great. I mean, look at how large those ventricles are. Go just look back at the other one and you'll see what we're talking about. And this is, interestingly enough, is a normal pressure hydrocephalus. So it's quite impressive looking. The common causes of increased cranial pressure then are summarized in this box, and you can take a look at this, and they make a lot of sense, but we have talked about the majority of those. Clinical manifestations for someone with ischemia. Well, whenever there's injury to the brain tissue, of course, headache is common. This can lead to vomiting, though, and an altered level of consciousness. So, in some cases, they can have blurry vision, papilledema, and even a decreased pupil responsiveness to light. Or some may become unresponsive to stimulation and unable to move, verbalize, or even open their eyes. If the ICP is prolonged, the elevated ICP is prolonged, then it's thought damage to the brain by, of course, through compression of the blood vessels, leading to ischemia. Evaluation then typically is done by inserting a pressure device directly into the brain through a burr hole, and then you measure the ICP waveforms. This picture is, of course, a picture of someone being monitored for intracranial pressure, and you manage patients like this based on what's causing the ICP as a result of which you can see what's causing it on CTs and MRIs. If possible, surgical intervention can be done, but many of the treatments are still very, very controversial. Most semesters, I have at least one or two of my students who have worked in emergency room situations, and you know how important neurologic evaluation is for someone who has sustained a head injury. One's levels of consciousness is still considered the most sensitive indicator of altered brain function. As we understand things, consciousness is dependent on activity in the reticular activating system neurons, and the level of consciousness can fluctuate throughout the course of a brain injury or disease. So we use the Glasgow Coma Scale to assess the level of consciousness those that have been acutely brain injured. And as you can see from the box, this is our typical categories where, first of all, eye opening and whether or not that they can spontaneously open their eyes. And all of these are given numbers so that you can figure out a particular value that assesses how affected they are. Of course, the higher the score, the better. The lower the score is suggestive of severe brain injury. And this picture is showing decorticate posture versus a decerebrate posture, of course, is indicative of significant injury affecting motor responses. Checking the pupil reflex is very common. It indicates function, of course, of the brainstem and cranial nerves 2 and 3. Pupils should change in size, shape, and reactivity to light. When they don't change, it's an early indicator of brain herniation. Eye movements themselves are controlled by cranial nerves 3, 4, and 6, and this can also be impaired with an increase in intracranial pressure, as well as some other things with nystagmus and disconjugate gaze. Even ocular palsies might be present. So looking at a brain injured, someone who has sustained a brain injury, their pupil reflex, of course, is one of the first things done. Ocular vestibular reflexes are also checked. If they are impaired, this implies, of course, dysfunction within the brainstem. And so they do two typical tests for this: the doll's eye maneuver, which entails rotating the patient's head from side to side, and the eyes should follow. And then the cold calorics, and you inject the cold water into the ear, and then there should be a suitable movement of the eyes. Both tests, of course, you're not going to want to do under different circumstances, so they have many contraindications. And you can see the normal response versus absent response with the doll's eye maneuver here in this picture. Another test that is used to assess brain function is the corneal reflex, where you just touch a little bit of cotton to the cornea of the eye to get a blink, and if you don't get a blink, this really is suggestive of severely impaired brain function. When a patient has sustained an acute brain injury, it appears that blood pressure is the most significant factor in early management. So we want to make sure that stays around 90 millimeters of mercury. Temperature, usually you're striving for normal temperature, although hypothermia sometimes is used to kind of reduce the metabolism occurring in the brain to reduce ischemia. Sometimes if you're inducing hyperventilation to result in vasoconstriction, it's wise to measure the cerebral oxygen extraction and cerebral oxygen tension to make sure that they're still getting enough oxygen and this sort of thing. So these are some of the things that you need to be aware of if you're dealing with patients that have acute brain injury. So let's go take a look at some of these traumatic brain injuries and what different symptoms that they can cause. So I'll start a discussion of acute brain disorders with a traumatic brain injury. It's pretty common. They estimate it's anywhere from 7 to 10 million cases per year. It's an estimate because they figure about 85% of them go unreported. However, 1.5 million are diagnosed, and it also leads to 50,000 deaths per year. At any given time, at least more than 5 million people are living with or disability as a result of traumatic brain injury. Risk factors, well, driving a motor vehicle. Those are one of the major causes, but falls and sports Accidents are also can lead to traumatic brain injury. Largest group in which this occurs are males 16 to 25, particularly if they are in lower socioeconomic groups as well. Best medicine, of course, is don't sustain a traumatic brain injury. And then, unfortunately, if that happens, early rescue and immediate emergency management can be very helpful. There are different types of traumatic brain injury. Severity, of course, first being determined by the Glasgow Coma Score. And of course, if it's less than 8 or less, that's indicative of severe injury. Moderate if the score is 9 to 12, and mild if it's greater than 12. Unfortunately, the Glasgow Coma Score is not really a good indicator of outcome. And then, of course, there's the primary injury, which is the damage to the neural tissue and the structures because of the impact. And there are different types of primary injury. There are the focal injuries, known as the COOP, and they're localized to the site of the impact. In these cases, you have specific neurological symptoms, but of course they're going to differ depending on where the site of impact was. And these can be minor to very severe. Another type of primary traumatic brain injury is a polar head injury, sometimes referred to as contra COOP. And this occurs because of shifting of the brain within the skull. And this is also going to stretch and sometimes shear the meninges. And during this course of acceleration and then deceleration, the abrupt stopped in the car because of the tree that the car ran into. Anyway, it results in localized injury in the two opposite poles of the brain. When it's the windshield is the obstacle, you have both the frontal and temporal lobes crushed. And this can lead to contusions and hemorrhage combined with edema. This, of course, is a significant mass lesion. The edema and mass effect, however, may not be symptomatic for up to 2 to 3 days. And this is the reason, in a lot of cases, for delayed deterioration in the brain injuries. Polar injuries may also play a role in cognitive impairment, which of course is going to affect recovery. And this, of course, is showing you the primary impact, and in this case, so did the secondary impact. It stops and you go forward and then backwards, but it's still primary injury. So far we've talked about local and polar head injuries. There's also what we refer to as diffuse head injury. And this is the result of movement of the brain within the cranial cavity. Again, as a result of acceleration and deceleration. In this case, we're talking about a rotational effect of the brain within the cranium. And this will stretch and shear axons, giving us this diffuse axonal injury. Injury is widespread, and it can be devastating on the function, of course, of the brain. Typically, patients are comatose from the time of injury. We'll have the abnormal posturing of the limbs, and recovery, if there is any, it's limited to a severely disabled or vegetative state. So it's not a good situation at all. Mechanisms of primary traumatic brain injury. Well, concussion. This is when the head injury alters consciousness, but there's no evidence of brain damage on physical or radiologic exam. And this is common of sports-related injuries. A contusion will show on CT or MRI an area of damaged brain tissue. So this could be necrotic or lacerated or bruised. And then intracranial hematoma. These occur when there's a localized bleeding and collection of the blood within the cranium. And this is again a result of vascular damage from the impact. Intracranial hematomas, they may expand slowly or rapidly. This is going to lead to an increase in ICP and then, of course, compressed brain structures. The types of hematomas differ in presentation and significance, so prompt recognition and treatment can improve their outcomes. And this is just kind of a picture here. It's kind of summarizing some of the different types of hematomas, the epidural versus subdural versus subarachnoid, but we'll talk about each of those individually. We'll start with our description of epidermal hematomas, or extradural. Now the blood is collecting in the epidermal space, which is between the inner surface of the skull and the dura mater. What happens with this is blood vessels in the dura are injured with the skull fracture. And the fractures of the temporal bone usually disrupt the middle meningeal artery, and so there's a rapid accumulation of blood and compressing of the brain. And when this happens, the clinical presentation, the severity of the primary injury may be, mild, and the patient suffers a brief period of altered consciousness. A lucid period occurs, and then boom, a rapid deterioration. Evaluation then is get a CT in there and surgical intervention quickly, but it has typically an excellent prognosis. Pictures are worth 1,000 words, so again, our little summary of the different types of hematomas that can occur, and then I've got a really good epidural one on the right. Even has the arrow, but I think most people would have been able to see that anyway. Subdural hematomas will form in the space between the dura and the outer arachnoid membrane. These are the ones that occur because of a sudden change in velocity. So these are the falls and the car accidents. And it's these bridging veins that will drain the venous blood from the surface of the brain that actually get stretched. And they get stretched and then they break apart. Because they're veins, then the hematoma is slower to form. And it's usually only severe if the trauma was really severe. So clinically, they're slow to develop and may not even be associated with the head trauma because it could have occurred as many as 10 days earlier. But there will be an increase in ICP as a result of the bleeding, and so this gives the patient the headache, the blurred vision, and the vomiting. In a lot of cases, the venous bleeding is self-limiting. In the elderly, however, who may have a lot of falls that go unremarked or unrecorded, this can accumulate and lead to changes in mentation, very similar to dementia. Subdural hematomas are usually evaluated with a CT and an MRI. And treatment, if it's large and localized, then you surgically remove it. If it's chronic, and then fibrosis and granulation form, these can then bleed again, and it's these chronic ones that have a tendency to form in the elderly. And this again is just a picture showing you the different hematomas, and this is a real significant chronic subdural hematoma that you see on the right. Finally, subarachnoid hemorrhages. These are arterial bleedings into the subarachnoid space. These, of course, that's the space, I should say, is formed between the arachnoid membrane and the pia mater, which, of course, is tightly bound to the brain surface. Anyway, these subarachnoid hemorrhages result from head injury, again, rupture of bridging veins, or more typically, the result of hypertension, an intracranial aneurysm, or an arteriovenous malformation. Symptoms with this, I forgot to hit these, sorry, include a headache, a stiff neck, and in some cases a secondary cerebral vasospasm. Anyway, what you're doing is narrowing the major vessels around the area of rupture, which occurs 4 to 14 days later, and two things occur: complications, ischemia, and hydrocephalus. So you evaluate this by the presence of red blood cells in the lumbar puncture, and that will clue the doctors in on a subarachnoid hemorrhage, and which we'll take a look at on the next slide. And as I said, here is, of course, our little picture on the left, but on the right is a significant hemorrhage in the subarachnoid space. Well, that's what happens as a result of the primary injury. What does the secondary injury, I should say, do in traumatic brain injuries? Well, these can actually be worse, the secondary mechanisms, and they can compound, obviously, the brain injury. And so you'll have hypotension and hypovolemia in some cases, bleeding out, and other areas of the body will lead to hypotension, and the hypovolemia, of course, within the brain means further ischemia. Chest trauma can compromise ventilation, decreasing oxygenation of the blood. Edema may occur 2 to 3 days later. Then the vessels may rebleed, and drainage to the cerebral spinal fluid can become clogged. And if there are open skull fractures, then infections can occur. All of this can lead to seizures, fevers, inflammation, and free radical production, which could lead to further brain injury. So, how do you treat traumatic brain injury? Well, management is directed at detecting and managing surgical lesions, reducing damage from secondary injury if possible. Keep them normal volemic, normal thermic, or maybe a mild hypothermia. Make sure they have sufficient glucose and oxygen. And if they have an increase in ICP, then do what you can to lower it. Diuretics, hyperventilation, drug-induced coma have all been tried, and in some cases worked, and others have not. Open head injuries, of course, are at risk for infection, so prophylactic antibiotics are recommended. Any discussion of acute brain disorders have to include a discussion of cerebrovascular disease and stroke. They are going to affect perfusion of the brain and lead to what's known as transient ischemic attacks, or an ischemic stroke, or hemorrhagic stroke. And of course, a stroke is referring to a localized area of infarction within the brain. Symptoms of stroke are going to be sudden in onset. They can be a numbness or a weakness of the face, arm, leg on one side, or confusion, trouble speaking or understanding. Sometimes a visual disturbance, dizziness, even a severe headache can be sign of a stroke. In terms of epidemiology, stroke is the third leading cause of death in the U.S. Most stroke victims, however, survive and require long-term care and rehabilitation. So it is the leading cause of serious disabilities. Most victims are over the age of 65, and females account for more than 61% of the fatalities. Risk factors for stroke are atherosclerosis, hypertension, diabetes, hyperlipidemia, smoking, age, and of course a family history. And if you've had a previous stroke, you are at increased risk, as does cardiac disease complicated by atrial fibrillation. So, we'll talk about the etiologies of strokes. They're either ischemic, in which case they're caused by thrombosis or an embolus or a hemorrhage. Ischemic strokes, there's of course a sudden occlusion of a cerebral artery secondary to a thrombus formation or an embolization. So, the best thing you can do is reduce your risk for this. Reduce the development of atherosclerosis and platelet aggregation, and try to prevent emboli from cardiac sources, which of course will include thrombi and growths from bacterial infection of the heart. Got to treat chronic atrial fibrillation because that can lead to clots, and so you treat that with anticoagulants and then antibiotics to prevent growth of microorganisms on the heart valves and things. Well, the mechanism of development, there's an obstruction. This leads to ischemia and cell death if it continues for several minutes. And then the cells surrounding the ischemic cells, known as penumbra, can be saved if the ischemia is mild or thrombolytic therapy started quickly, which means within 3 hours of the stroke. So that can save the surrounding cells. addition, if an obstructing clot is dissolved by the fibrinolytic system, typically we see the neurologic deficits resolve, in which case we call it a transient ischemic attack or a TIA. TIAs raise the risk of stroke tenfold, and so they should precipitate someone being put on aspirin therapy, unless, of course, there are reasons for not putting them on that. Clinical presentation, as always, with the brain, it's going to depend on the area of the brain that's affected. So, the middle cerebral artery is frequently occluded, and this leads to damage in the lateral hemispheres, and contralateral hemiplegia, visual field blindness, or hemisensory loss occurs as a result of that. Occlusions of small penetrating arterioles can produce smaller lesions. These are referred to as lacunar infarcts, and they may not even be visible on the CT, but they have a really good prognosis. Usually they affect motor or sensory functions. This figure just shows you how the brain is perfused and what areas might be affected should a thrombus or some other occlusion block the blood flow in any one of these particular blood vessels. The other type of stroke is a hemorrhagic stroke. It's typically caused by severe and long-standing hypertension. Carries a very high percent of mortality, about 38%, and with death occurring within minutes to hours. Pathologically, there is a bleed, usually in the basal ganglia, the thalamus. When large, of course, this is going to lead to an increase in ICP. This is going to lead to herniation and death. Prognosis, not surprisingly, will depend on one's age, the location, and the size of the hemorrhage. Secondary injury in hemorrhagic stroke usually is greater and leads to more morbidity and mortality. So, how are strokes treated? Well, try to limit the size of the infarction, support the body functions, and prevent further cerebral ischemia. Can initiate aggressive rehabilitation strategies and prevent additional strokes. Acute therapy with thrombolytic agents may limit the infarct size in some patients, but that's more in those with an ischemic stroke than a hemorrhagic stroke. Problems come with those who survive with all the complications that can occur as a stroke. In fact, strokes are associated with long-term deficits in motor, sensory, language, and cognitive abilities. Sometimes I think I have no language abilities, but that's beside the point. Anyway, motor deficits initially characterized by a flaccid paralysis, and this will be a loss of muscle tone in the affected extremities. So that things like a foot drop or an outward rotation of the leg, and then dependent edema in the lower extremities is also seen. Shoulder separation can be seen in the upper extremities, and recovery about 6 weeks after the stroke will be indicated by spastic responses in that extremity, and that's actually a good sign. Any sensory impairments are going to occur in the same location as the motor paralysis. And we can talk about things like a neglect, where the patient is not aware of the body part that was affected. They'll have a loss of visual field on that size, which contributes to it. And they can then sustain several types of injuries without realizing it. So that can be a problem. And then you can have the homonymous hemianopsia. This is where the contralateral field blindness occurs because the same side of the retina in each eye is affected. Let me get a picture of this coming up. And then, of course, there are all the language deficits that may occur. Aphasia, of course, is a broader term, but include problems with verbalization. I always think that's one of mine. Auditory comprehension and nonsensical speech. And then memory, reasoning, and a reduced ability to repeat words. And this is just showing you the problems that you can have with the blindness occurring on the same side and this sort of thing. Don't worry about this particular. Unfortunately, we never really have time to talk about sensory chapters. We talk about eyes and ears and this sort of thing, which is really kind of too bad because that's some of the more common things, but that can be seen in clinics and everything, but we just never have time. So maybe if we go to an all recording sort of thing, I can add it and we'll see. Anyway, let's move on. Other types of acute brain injury include aneurysms. This is a lesion in a blood vessel. This, of course, usually results in a dilation and ballooning of it, and of course that will have a tendency to weaken it, and so it ruptures. This occurs in about 6 in every million, more common in women than men, and it's usually fairly younger ages, between the ages of 30 to 60, may go unnoticed and diagnosed, but there are factors that will contribute to it, such as alcoholism, high blood pressure, cocaine use, and of course cocaine use, I should say. I just always wonder why people do it, but that's okay. Now, you can have a saccular aneurysm, which is due to a congenital defect in the medial layer. This allows it to balloon, will develop over years as a result of weakness and arterial pressure. Where do these typically occur? At the circle of Willis, because there's that turbulent flow there. And these are just some really good pictures. The one on the left, of course, is showing you where they commonly occur, the percentages around the circle of Willis. And here's one, a very large one, of course, that then went on to rupture. So the clinical presentation, people do have what's referred to as warning leaks. And this gives them really bad headaches, worse than they've ever had, and then they get the photophobia and the stiff neck, and this is because of the blood in the cerebral spinal fluid. After it ruptures, there'll be a sudden increase, of course, in the intracranial pressure. This can lead to distortion of the intracranial tissues, and then you have a secondary vasospasm induced by the blood in the cerebral spinal fluid. This typically occurs 4 to 14 days later, further decreasing the blood flow, and then cerebral blood flow, but then rebleeding and hydrocephalus can occur. So if it isn't severe right off, this is the other things that can happen. Typically, you evaluate it with a CT or MRI, a lumbar puncture, and a cerebral angiogram to locate it precisely. And you need to surgically stabilize it and aggressively prevent the secondary vasospasms. Arteriovenous malformations. They are, again, a type of vascular lesion. We think of them typically as being congenital, but they're not diagnosed until the patients are usually in their 20s to 40s. It seems that some of the capillary system fails to develop, and instead of the arterial blood going into various smaller blood vessels and finally into the capillary and then into the venous system, the arterial blood is shunted directly into the venous system. So you've got this high pressure arterial system causing the veins and the surrounding blood vessels to enlarge. And basically it just becomes this congested mass and is vulnerable, not surprisingly. And I meant to say, not surprisingly, vulnerable to hemorrhage. Well, anyway, how do they present clinically? Well, hemorrhage in 50%, seizures in 25%, and this sort of vascular steal syndrome in the other remaining people, in which there's a progressive neurological dysfunction from ischemia. So treat them. These are usually surgically removed, radiated, or even a glue embolization, I guess, can be done, and then supportive therapy for bleeding and any rupture and this sort of thing. And you can see a picture of a AVM on your right. And this picture just shows you that this can indeed be successfully treated. And you can see the one on the left, and then after the surgical repair, you have a much nicer little picture on the right. So, this can then lead us into a discussion of infections of the central nervous system, which includes meningitis, encephalitis, and my personal favorite, abscesses. Actually, I'm just kidding about the abscesses. Let's talk about meningitis first. Meningitis, of course, is microbial infection of the central nervous system. So we have inflammation of the membranes of the brain, the spinal cord, most commonly by bacteria, but it can occur by viruses and fungi as well. Typically, they're coming from the bloodstream, but they can also come from infected ears or sinuses. Any kind of penetrating head wound can contribute to this as well as skull fractures or neurosurgery. In children, typically we see infections of meningitis with Streptococcus pneumoniae, Neisseria meningitidis, of course, and Haemophilus influenza type B in those who weren't given that particular vaccine. How does it develop? Well, with bacterial meningitis, the pyogenic infection gets into the cell arachnoid space, travels throughout the brain and spinal cord, and leads to inflammation. And the accumulation of the inflammatory exudate can lead to obstructive hydrocephalus, and serious complications can increase the ICP. Symptoms, again, acute onset with fever, stiff neck, headache, confusion, delirium, and or seizures can occur. Diagnosis is typically done with a lumbar puncture. This will be sent, of course, for a gram stain. And you also analyze the cerebrospinal fluid for increase in white blood cells and proteins and a decrease in glucose because the bacteria are eating the glucose. So that's classic for bacterial meningitis. And when it is bacteria, you give them an antibiotic. Now, of course, my pictures. This is an extremely swollen brain as a result of a bacterial meningitis. Encephalitis is defined as inflammation of the brain caused by the same infectious organisms as meningitis, but typically it's thought of more as being a viral. West Nile virus is now the more common cause of encephalitis in this country. It has been since just 1999, 10 years. Other causes of this can, however, be Western equine encephalitis and herpes simplex viruses, or HSV. Both the West Nile and Western equine are transmitted by mosquitoes, and birds are the preferred hosts for those viruses. HSV1 can cause a sporadic encephalitis. Unfortunately, it is often fatal. Clinical manifestations with West Nile, typically it develops 3 to 14 days after exposure to the virus, and so you get sort of an asymptomatic or febrile illness with a headache, malaise, muscle pain, or rash. Severe infections will have fever, flaccid paralysis, headache, and of course changes in mentation. With the Western equine virus, similar incubation period, but then a very more rapid onset of the general malaise, the headache, and the nausea and vomiting. Temperature is only moderately increased. That's more common for viruses. And the headache is really severe, so the patient gets lethargic and, not surprisingly, irritable. It either subsides in 10 days or proceeds to stupor, coma, and death. So it can be very nasty. And this is just a picture showing you what the West Nile virus actually looks like with an electron microscope, and the transmission of West Nile virus on the right, which is provided by CDC's website. The herpes simplex infections, this can be a result of a primary, secondary, or reactivation of the latent virus. Doesn't have any seasonal incidence at all, and it can cause what's known as an acute hemorrhagic necrotizing encephalitis. So you've got bleeding and a lot of cell death occurring. It'll present with more flu-like symptoms and memory impairment. Personality changes can occur with this, and then of course they can rapidly go downhill to confusion, delirium, and coma. You will see an increase in white blood cells with the herpes. perhaps a slight increase in the protein, but the glucose will be normal because viruses don't have any metabolic activities, and so the glucose will not be used up. Why is it important to identify? Well, one, it tends to be rather severe, and two, you can treat it with a cyclovir. So it's important to recognize some of the different symptoms. And this, of course, otherwise, with encephalitis, it's very important in terms of treatment, to give supportive treatment and try to treat the various symptoms, control seizures if they start to develop, and of course the ICP. And steroids are quite useful for the controlling the edema that can develop. And you can see sort of the areas, the necrotic areas in the picture of the brain to your right. This leads us to a discussion of brain abscesses, in which case you've got basically a collection of pus within the brain. Why is it there? Well, there was an infection with a pyogenic pathogen. In other words, pathogen that produces a vigorous response with neutrophils and stuff. You see this with people who have had a penetrating wound, or it's coming from a neighboring structure, sinusitis, anything. You can also see it from bloodborne dissemination. Staph, strep, and various anaerobes are common organisms that induce formation of brain abscesses. Pathogenesis and the symptoms, well, as it says, it's a space-occupying lesion. So the patients will have symptoms 1 to 4 weeks after infection, and a central portion will have neutrophils and the pus in there. The peripheral portion of the abscess is going to have the inflammatory granulation tissue. And surrounding the abscess, classically, is proliferation of surviving astrocytes. The CT scan shows this outer rings surrounding a low-density core, which you can see on your right here. It's very obvious with it surrounding the area. Treatment, well, it's going to depend on where it's located in the brain. If possible, you can drain it and excise it. Obviously, IV antibiotics for several weeks, and post-infection care deals with any neurologic deficits that may have occurred as a result of the abscess. So that concludes our discussion of acute brain disorders, and we'll get into our chronic disorders in the next chapter. So Chapter 45 does indeed discuss the chronic disorders of neurologic function, which is displayed by this picture here from someone who is suffering from Parkinson's disease. We'll start off with brain and cerebellar disorders. This will include seizure disorders, dementia, Parkinson's, and cerebral palsy. Seizure disorder is defined as a transient neurological event. Basically, there are abnormal, excessive cortical electrical discharges. This will manifest itself as a disturbance either in skeletal motor function or sensation, occasionally autonomic visceral function, behavior, and even, of course, consciousness. Epilepsy refers to a disorder then of recurring seizures. And its etiology, well, when it's acquired, it seems to be a result of cerebral injury, potentially tumors, blood clots, even infection, and metabolic and nutritional disorders. Electrolyte and water disturbances can lead to this. Alcohol withdrawal can, as well as medication overdose. Structural changes may also lead to a seizure disorder, and there are those from which we have no idea why they are occurring. So those are our idiopathic ones. The triggers for a seizure seems to differ for every individual, but a lot of sensory stimuli seem to be the triggers. So flashing lights, maybe loud noises, rhythmic music. There was that one video game from Japan that got kids for a while there. Fever is a classic trigger. Physical exhaustion, perhaps poor nutrition, For women, this can be when they're menstruating, also hyperventilating, injury, and drugs. Not surprisingly, can trigger it. Psychosocial families, though, can trigger a seizure as well, and of course, including stress, shock, and of course, the family things that may have lead to this. Well, how it develops, we do know that there is an alteration in the membrane potential, and somehow, as a result of this, the neurons are hyperactive, and they will be hypersensitive to any kind of change in their environment. And this hypersensitivity means, of course, they're going to become depolarized. And so it will initially form what's referred to as an epileptogenic focus, and this is from where the seizure emanates in the brain. And unfortunately, what it does is it shoots out large numbers of these discharges, leading to action potentials, recruiting other neurons in the adjacent areas. And, of course, also depending on the neurotransmitter at that particular postsynaptic membrane. Well, after we've got the focus and the triggering, what we get is a number of different types of seizures, and this is how they are classified. You have a partial seizure, which only involves a portion of the hemisphere of the brain. These partial seizures can be simple, where the patient remains conscious, and then the symptoms may be some motor, sensory, or autonomic, or a combination of those. They can be complex when many different cognitive, affective, and psychomotor symptoms occur together. Complex can also have an altered or loss of consciousness. Onset with complex typically involve repetitive movements like lip smacking. Had a dog that had epilepsy, and his always would start with his snapping his jaw and this sort of thing. Aggressive behavior may occur as a result of this. It lasts several minutes, and then unfortunately it's followed by this post-ictal state, which is what really scares everybody, because then they're unresponsive and things like that. Partial seizures, however, may also secondarily generalize, and these will then be more similar to general seizures, which we'll discuss on the next slide. General seizures are going to involve the entire brain, and it will spread to the reticular activating system, and so the patient will have a loss of consciousness when these occur. These can be absent or petit mal. These occur in children. They have a brief staring spell, and then their academic performance begins to decline. But I know someone who developed the epilepsy as a result of eclampsia, and she is in her 40s and still occasionally has these absence seizures. A typical absence seizures will have a staring spell with, say, a single myoclonic jerk. An atonic drop seizure may be associated with a myoclonic, but you have a sudden and complete loss of muscle tone, so they drop. Clonic seizures, you're going to have the jerking of the muscles. Tonic seizures, you have the stiffening. And then the grand mal, you get everything. You lose the consciousness, you drop to the ground, you open the eyes and mouth with the extension. And then some of the things that are really upsetting for someone who has never experienced this before, when somebody else, well, the jaws can snap shut and they inadvertently bite their tongue. And as they go through the tonic and clonic seizures, then you can hear this high-pitched cry as the whole musculature is seized. Skin and mucous membranes can become cyanotic. Bowel and bladder typically empty, so that's your tonic phase. Clonic phase, you get the trembling and the muscle contractions. And then, of course, the terminal or post-ictal phase, and there's absence of movement, and this can last 5 minutes. And then when they open their eyes, they are disoriented, they're confused, and they don't remember it at all. One of the things that, of course, they are concerned about with someone who has epilepsy, recurrent episodes, is something called status epilepticus, and this is a continuing series of seizures without that period of recovery, without the post-ictal phase. Because of this increase in metabolic activity that occurs during the seizures, if this is ongoing, what can happen is it can decrease the glucose stores and actually lead to ischemia because of the increased oxygen requirements. And then you start to get a serious brain injury. Most people who have epilepsy talk about they get the sense that this is going to occur. They have this aura prodrome, and this is subjective sense of impending seizure. And they may have a little clonic jerking or a headache, lethargy, mood alterations, palpitations, or even epigastric sensations. Diagnosis of epilepsy is based on history, physical and neurological exam, and an EEG. Lab studies are going to rule out anything metabolic, and then you monitor, of course, the therapeutic drug levels when you treat it. Treatment then, you want to try to limit the number of seizures, make sure that when they do have one, though that the airway remains open and they don't injure themselves as they go through it. So anticonvulsant medications are pretty common and they're used to prevent the seizures. Well, then we can talk about dementia. This is defined as a syndrome associated with a lot of different pathologic processes. In other words, a lot of different things can lead to dementia. But it is characterized by progressive degeneration of memory and then other cognitive functions, and it's due to an actual cause or an organic cause. Onset is typically insidious. Person can appear disinterested or lack initiative. Gradual forgetfulness, and finally language and physical abilities will become impaired. Many of them will have I can never say this word all that well, so I'm not going to try, but it's a lack of insight into their cognitive deficiency, so they're unaware of this. And however, they may also have disruption of sleep patterns. I always worry about language disabilities when I find a word like that. For some reason, my tongue just won't wrap around the one on the previous slide. But anyway, with dementia, it is fourth leading cause of death. Affects up to 30 to 50% of people over the age of 85. Typical onset is 65, and unfortunately, in many cases, it's the result of Alzheimer's disease. Etiology then is Alzheimer, but people with multiple infarcts, ischemic attacks, this sort of thing can lead to this. Alcoholism, tumors, Huntington disease, a genetic disorder. Syphilis, tertiary syphilis can lead to dementia. It can be idiopathic. It can be a result of Parkinson's disease. Lewy body disease is kind of a form of Parkinson in some cases. But multiple sclerosis, Creutzfeldt-Jakob disease, and even variant CJD known as mad cow. The CJD stands for Creutzfeldt-Jakob disease. Well, risk factors for Alzheimer, of course, include your age as you get older, if there's a family history of it. If it's familial, then your onset is earlier. You're less than 65. If it's sporadic, you're over 65 when it develops. And we do see an association of the development of Alzheimer's with mutations in chromosome 1, 14, and 21. These are in genes known as presenilin 2, presenilin 1, and beta amyloid precursor protein, or APP. These are all linked to an early onset of Alzheimer's. Also, the presence of apolipoprotein E4 on chromosome 19. This is a particular allele of apolipoprotein E4. Apolipoprotein E seems to increase one risk, and we see the accumulation of ApoE4 in some of the tangles and plaques that are forming in the brain of people with Alzheimer's. So how does Alzheimer's develop? Well, Alzheimer's occurs as a result of lesions in the cerebral hemispheres and the diencephalon. Temporal and frontal lobes are also involved, and the Alzheimer's brain at autopsy reveals the following development. There are these tangles, these what they refer to as neurofibrillary tangles, which are actually dying neurons. In addition, you see amyloid plaque deposits that are classic for Alzheimer's. The number of these plaques will correlate with the degree of dementia. So the more plaques you have, the more demented you were, if you had it. And as a result of the dying neurons and the accumulation of these amyloid plaques, basically the brain is atrophying. It's getting smaller. And you can see that. Fourth, they're going to lose cognitive abilities, motor abilities, and everything else. Components of course, we've been studying the neurofibrillary tangles and plaques to a great extent. And we find that they contain things called tau proteins, which forms these abnormal shapes of the proteins. Beta amyloid is a protein whose gene is located, guess where? Chromosome 21. And remember, Down syndrome patients typically develop Alzheimer's early. So too much of this 21 beta amyloid seems to contribute. And of course, I had to have some pictures of the neurofibrillary tangles and the amyloid plaques, which you can see on the left and on the right. Well, the formation of these tangles and the plaques initiates, guess what? Inflammation, particularly a complement activation, and then of course the microglia that are derived from monocytes get activated. Damage, of course, as a result of the inflammation will affect nerve cell communication, metabolism, and repair. And so one of the things they see is a decrease in acetylcholine synthesis in Alzheimer patients. Histologically, the Alzheimer changes also occur in vascular dementia, where there's cerebral damage because of vascular disorders and accumulating infarcts, this sort of thing. So you still see some of the Alzheimer changes in this type of dementia as well. Well, the increased risk of Alzheimer is linked to a lot of things, but particularly hypertension, peripheral vascular disease, lower education, surprisingly, estrogen levels, traumatic brain injury, and an increase in homocysteine. All of these seem to increase one's risk. Clinical manifestations of this disorder, well, gradual onset, progressive decline in cognitive functioning, short-term memory loss, long-term preserved. Thinking ability decreases, a decreased ability to function at work and socially. They are anxious, they're agitated, they have increasing problems with judgment, problem solving, communication, difficulty eating, swallowing, weight loss, and of course loss of bladder and bowel function, and then ambulation can occur as well. Accidents and infection are common as a result of this, and then typically can lead to their death. Diagnosis and treatment. Well, we don't have usually diagnosis of Alzheimer's isn't completed until autopsy, but complete history, physical exam, basically you will rule out other things, and you just check their overall health and any pre-existing conditions and medications that might put them at risk. The PET scans, they measure glucose metabolism, and typically they do see a decreased pattern in cerebral glucose. This has been used with history for perhaps an early diagnosis. 2 classes of drugs are approved for use. One of them are the inhibitors of the acetylcholinesterase enzyme. That's, if you recall, is found within the postsynaptic neurons to break down acetylcholinesterase in the synapse, so there's not too much. Well, people with Alzheimer's are not producing enough acetylcholine, so you block the enzymes and you can slow the progression of it. And then also block the receptor of the glutamate stimulation, which seems to also decrease metabolism and slow progression. And just some pictures here. This is showing you the normal brain and the Alzheimer brain, showing you differences in glucose metabolism within the brains. And this is just showing you the mechanism of action for the inhibitors of the acetylcholinesterase, and why this would, what acetylcholine that's being produced by the Alzheimer patient would then be there longer in the synapse, so more likely to have an effect, and as you can see, then slow progression. Parkinson's disease is another common disorder. It affects up to 1% of the population over 50. Highest incidence seems to occur in people between the ages 45 and 65. All ethnic groups are represented, and there's an equal distribution in gender, so we are all capable of developing this. Etiology is either idiopathic, we don't know why, or it's acquired as a result of exposure to certain street drugs, phenothiazine drugs, infection, or trauma. Again, the onset is insidious. We know a little bit more about what is lost in Parkinson's, but we're not sure why. We do know that there's a decrease in dopamine production, and this is because the pigmented dopaminergic cells in the basal ganglia, particularly the substantia nigra, are deteriorating. Lewy bodies, which are eosinophilic inclusions, and amyloid plaques can also be found in that area. As I said, we don't know the exact cause for the deterioration of these cells, but lots of things have been implicated, such as oxidative stress, genetics, and environmental toxins. Regardless of the cause, which in many cases we don't know, we lose the cells that can make dopamine. That's the ultimate result of this disorder. We've found that people who have mutations in a gene known as alpha-synuclein, which is found in neurons, is also found in these Lewy bodies that are associated with Parkinson's, and these Lewy bodies accumulate in the brain in the patients. Also, there's a gene that we refer to as the Parkin gene, and mutations in that seem to lead to abnormal protein breakdown and clearance. And so these accumulate again in the neurons, injuring the neurons, but specifically in the neurons of substantia nigra. Well, onset doesn't begin until up to 80% of the neurons are affected. And this is another PET scan where you see differences between a healthy control in that particular area, substantia nigra, versus someone with Parkinson's disease. And you can see there are fewer cells that are present, and therefore lower levels of dopamine being produced. Clinical manifestation are associated with symptoms of motor impairment. So particularly difficulty initiating and then controlling the movements. So they have akinesia, tremor, and the classic rigidity. Early signs seem to be a loss of flexibility, aching, and fatigue. In many cases, it's attributed to just aging. Tremor is present about 70%, in fact, may be the presenting symptom. Other signs: loss of facial expression, infrequent eye blinking. Handwriting can become small and cramped, with, of course, evidence of tremor. Speech becomes low in volume, monotonous. It would be pretty awful if I didn't try to, change my way of speaking a little bit during this stuff. But that can happen. Swallowing can become delayed, and so they frequently drool, can even aspirate into the lungs. And then the movement, the characteristic walking that they have. It's slow, it's stooped with the tremor. However, they can act very quickly in emergency situations. Well, they also have problems with the autonomic nervous system, so they can have orthostatic hypertension. Falling is a common problem with them. And of course, with all this occurring, depression occurs in at least 50% of them. They'll have daytime sleepiness, even dementia, and unfortunately we have no known cure, but drugs can optimize function for a time. So we can restore the dopamine levels by adding either dopamine precursors, dopamine agonists, even monoamine oxidase inhibitors, which break down dopamine, and anticholinergics. Surgical options include deep brain stimulation and this sort of thing, and of course, the ultimate goal with tissue transplantation if we can use the cerebral stem cells to replace that area. And of course, here again is the picture of a classic presentation with the walking of someone with Parkinson's, the tremor, the mask-like face, and this sort of thing. So you can take a look at that. We'll move on then with a discussion of cerebral palsy. This is actually a diverse group of disorders that can be quite crippling. They typically appear during childhood and always involve permanent, non-progressive though, encephalopathic damage to the developing brain. Etiology, it's usually present at birth or shortly thereafter, remains throughout life. What causes it? Potentially prenatal infections or some diseases of the mother. Mechanical trauma to the head before, during, or after birth may put them at risk for this. Nerve-damaging poisons or reduced oxygen supply all seem to increase their risk for developing it. And additional risk factors: neonatal hypoglycemia, kernicterus, too much bilirubin. If they're premature or they have a low birth weight, they're also at risk for developing cerebral palsy. Clinical manifestations, they have different types of kind of cerebral palsies. The spastic cerebral palsy is what occurs in the majority of them, and they'll have hypertonia, prolonged, what we refer to as primitive reflexes, exaggerated deep tendon reflexes, clonus, rigidity of the extremities. Typically scoliosis and contractures occur with this, and it can affect one side or both sides or one extremity or all four of them. If they have the dyskinetic cerebral palsy, they have the jerky, uncontrolled, abrupt movements, the ataxic cerebral palsy, the gait disturbances and instability. They'll be hypotonic at birth, but then stiffness of the trunk muscles develop. This is kind of rare. Mixed disorders, more common. And finally, they can also have neurological complications such as seizures, intellectual problems, and visual problems. Treatment then will depend on the nature and extent of the brain damage. Muscle relaxants can reduce the spasms in many cases. Botox seems to be helpful with that. Anticonvulsants if they have seizures. Orthopedic surgery. Casts and braces can help to retrain the muscles, and special exercises to make it easy for them to ambulate. And this is just kind of giving you a picture of the different types of cerebral palsy that can occur. Bell palsy is another type of cerebral palsy where the facial nerve, particularly cranial nerve number 7, is affected, and you have these areas of peripheral facial paralysis. We'll end our discussion of nervous system disorders with talking about some of the spinal cord and peripheral nervous disorders that can occur. Starting off with multiple sclerosis, Guillain-Barré, amyotrophic lateral sclerosis, spinal cord injury, and finally spina bifida. So we'll start with one that wasn't even listed there, and that is hydrocephalus. And this is going to be characterized, of course, by abnormal accumulation of fluid in the cerebroventricular system. You can have a normal pressure hydrocephalus, which is due to an increased volume of cerebrospinal fluid, an obstructive hydrocephalus due to an obstruction, and a communicating hydrocephalus occurs due to abnormal absorption of the cerebrospinal fluid. And those different ones are kind of shown on the bottom here with the various pictures. Unfortunately, medical treatment for hydrocephalus is limited. However, obstructions can be corrected surgically, and the most effective treatment for managing them is a surgical correction employing a shunt so it doesn't accumulate again. Well, then we'll get into a discussion of multiple sclerosis. I could spend a lot of time talking about this because I did my PhD dissertation on research on multiple sclerosis, but I'll be kind to you all and just kind of keep it short. First of all, we got to define it. It is a chronic demyelinating disease of the central nervous system, and it's going to cause significant disability, predominantly in young adults. Incidence, it's very common in people of Northern European descent. However, environmental factors contribute as well, including geography, exposure to certain infectious organisms, all of which prior to the age of 15 can put you at greater risk. Genetics are also going to influence development of MS. We do know that it is an autoimmune disease. It is mediated by T cells that are specific for myelin basic protein. The protein is important in the formation of the myelin sheath around the axons, but it will then disrupt, of course, conduction of the signals from the nerve to the muscles. And this picture is just giving you a classic picture of how the T cells, the autoimmune T cells, get activated and then respond to the myelin. And they go on to initiate inflammation and to actually also help B cells produce that have antibodies that might bind the myelin basic protein as well. And then they get activated and they bind. And again, of course, you've got both a type 2 and a type 4 hypersensitivity occurring and resulting in destruction of the myelin sheath and then poor nerve conduction. The actual demyelation can occur anywhere throughout the central nervous system, but typically it'll affect the optic nerve, so they'll have double vision, ocular motor nerves, leading to an ascending paralysis, so it starts in the legs and then moves up to the arms. The corticospinal, cerebellar, and posterior column systems are affected, so bowel and bladder function can be affected, and then memory and personality changes occur in the later stages. Remember that the myelin facilitates the nerve conduction, so inflammation and scarring of it slows or interrupts the nerve conduction. We don't know what actually triggers it, but we do know that certain infections and exposures to some toxic substances have seemed to correlate with a spike in the incidence of MS in certain populations. Whatever, an autoimmune response is being generated in genetically susceptible people. Both T cells and B cells are implicated. And this is a picture showing you that where the demyelination can occur and either side of these. And of course, that's going to affect transmission or conduction of the action potential. MS is typically a slowly progressive disease. Basically, it takes from diagnosis until the time they are wheelchair bound about 20 years. So, and they'll have exacerbations and remissions, but during the remissions, they never get a full return of function. There are 4 possible courses of the disease, but we're not going to go into that here. We don't really have the time. Clinical manifestations and diagnosis. Diagnosis can be difficult because it can present very differently from one person to another. But blurred vision, diplopia, weakness, tingling, extreme fatigue, imbalance, start getting movement disorders, spasticity, difficulties with coordination, gait, bladder, bowel function, vertigo, pain, paresthesia, all of this can be the initiation of MS. Neurobehavioral symptoms can also occur: depression, emotional instability, sexual, memory, and cognitive impairment can also occur. There is no conclusive test for MS. Diagnosis basically is based on clinical characteristics and lab evidence, and evidence of 2 attacks that were remitting or relapsing, and then in some cases in MRI. Symptom treatment, basically symptomatic. There has been some success with steroid therapy and these beta interferons and certain statins. So there is, but this is just a picture of what a plaque looks like. And a plaque in MS is basically a lot of immune cells, T cells and B cells, surrounding the nerve axon and destroying the myelin. Guillain-Barré syndrome is also another type of disorder that leads to paralysis. It's what we refer to as an acute infectious polyneuropathy or polyradiculoneuritis. It is an inflammatory disease, but typically of the peripheral nervous system. Incidence, it's about zero point 0.6 to 1.9 cases per 100,000. However, there is an increasing incidence in the aging population. It is the most common cause, however, of non-traumatic paralysis in the Western world. Again, no gender bias, so we're all equally susceptible. We don't really know the cause all that well, but 50% of the patients have had a viral infection prior to development of the symptoms. Can also follow inoculations or surgical procedures, and infection with a Campylobacter has also been associated with the development of Guillain-Barré. Pathophysiologically, we do know that the immune system is activated. Which aspect of the immune system is not all that known. There is segmental demyelination. We see both B cells and T cells activated in this. Aggregates of lymphocytes again are found at the site of demyelination, and of course this slows or stops nerve conduction. Motor neurons are primarily affected in Guillain-Barré, but some sensory nerves can be involved. Again, this is an ascending type of paralysis, which begins in the legs, spreads to the arms and face. Respiratory muscles, however, can be affected, and this occurs a lot faster. They may have the paresthesias and diasthesia. Anyway, at the peak, which is usually about 10 to 14 days after this sort of started, they can have a loss of autonomic function. Blood pressure, cardiac rhythm, ventilation, all this can be affected, and so they are usually in an ICU and require support, serious support. However, a lot of them spontaneously recover. Plasmapheresis, which will remove antibodies and other substances like that, seems to help at the peak. A lot of them get full recovery. Some have mild disability afterwards. So if you have to have an ascending paralysis, this is sort of the one to have because most people recover, but not always. And this is just a picture of all the lymphocytes that you would see, and that's an increased number of lymphocytes in the bloodstream there, people. Well, next we can talk about amyotrophic lateral sclerosis, ALS, otherwise known as Lou Gehrig's disease. It's defined as a progressive degenerative disease. It's going to affect both upper and lower motor neurons. Leads to muscle wasting, atrophy of hands, arms, and legs. It's fortunately not all that common. Only 5,000 Americans are diagnosed with this per year. It's more common in men between the ages of 40 to 60. It's usually sporadic, but there are some familial cases. We do have identified 4 different genetic mutations that might be responsible for this. One of them is in a gene known as superoxide dismutase 1, or SOD1. This seems to lead to premature apoptosis of the neurons. Okay, so that could lead to degeneration of the neurons. The neurons we know are particularly susceptible to injury by not only oxygen radicals but inflammation, which will, of course, exacerbate the injury. This picture just shows you that the neurons themselves actually deteriorate, and of course this can lead to a loss of motor function. Clinical manifestation begins with a weakness and a wasting in the upper extremities. Then it's followed by impaired speech, swallowing, and respiration. Mean survival time from diagnosis, typically about 3 years. Diagnosis, again, usually based on exclusion, signs and symptoms. Certain nerve conduction studies can also implicate ALS. There is no known cure, but glutamate inhibitors can prolong life because they do see elevated levels of glutamate in the cerebral spinal fluid, and that, of course, can damage the neurons. And these glutamate inhibitors will delay the need for mechanical ventilation. Supportive care for both physical and emotional needs are going to be needed for these patients. Well, then we get into a discussion of spinal cord injury. And this is typically a disease of the young. 65% of the people with spinal cord injury are less than 35. Greatest incidence between the ages of 20 and 24. Males are commonly affected during the weekend and summer months when they are their weekend warriors participating in dangerous sports and things like that. So, spinal cord injury is usually traumatic: car accidents, falls, penetrating wounds, or sports accidents, and can result from compression, contusion, or actual transection of the spinal cord. Pathologically, if it's a flexion, then you have a tearing of the ligaments and dislocation. This is giving you your most severe injuries. Hyperextension, however, are the most common. Compression will crush it. And of course, secondary injury can, as a result of hemorrhage and necrosis of the spinal cord, can follow. This picture, of course, demonstrates the different types of spinal cord injury: flexion, hyperextension, and the compression. And I can tell you about the compression because I sustain that, but not by diving into too small a pool of water, falling off a galloping horse. I hate to admit it. Spinal cord damage is caused by a variety of factors. These include morphologic damage, so you've actually, injured it. Then you can have hemorrhage, vascular damage, ischemia. You can lose the autoregulation, which of course is very important, particularly right after the injury. This can lead to ischemia, and it's important to treat this within 60 to 90 minutes. Structural changes will occur in the gray and white matter. Damage with this is rapid, so 70% of the cord at the site can be destroyed within 24 hours. The damage will extend a little above and below the level of injury. Spinal shock can follow a traumatic injury, and it's a physiologic disruption of the function of the spinal cord. It can be temporary suspension of function, and of course you're going to have the reflexes below the level of injury affected. It usually occurs immediately after the injury, but occasionally it can occur a little bit later. The muscles, of course, that are affected are flaccid, and both the skeletal and autonomic reflexes are lost. A return of the spinal reflexes in spastic paraplegia or quadriplegia will indicate an end to spinal shock, and this can occur within 24 hours to several days. In contrast, neurogenic shock will occur in cervical or upper thoracic spinal cord injury, and this is life-threatening. It typically is actually a form of distributed shock caused by loss of brain stem and higher center control of the sympathetic nervous system. What that means is you get hypotension because of peripheral vasodilation. Bradycardia, circulatory collapse then can occur. High spinal cord injuries may also affect respiratory muscles, and then you have the ventilatory failure. Loss of ability to sweat, also below the level of injury, will occur. Autonomic dysreflexia. This is something that occurs at or above injuries to the T6 vertebra. Again, this can be life-threatening. It's basically an acute reflexive response to any kind of sympathetic activation below the level of injury. This can be visceral or cutaneous pain receptors, just a full bladder, or even constipation. And what happens is you get this sudden episode of hypertension, headache, bradycardia, upper body flushing, lower body vasoconstriction, piloerection, so you get those goosebumps and sweating. Well, when anyone sustains a spinal cord injury, treatment, first of all, is stabilization of the spinal vertebra, so you don't cause any further injury. If they're a neurogenic shock, you, of course, have to get them to the ICU. If they have the autonomic reflexia, you got to remove the source of irritation and give beta blockers, especially if the hypertension won't go away, because this could lead to an increase in ICP. And then you got to prevent infection with prophylactic antibiotics. Rehabilitation, of course, can be lengthy and ultimately is aimed at independence and self-care. We will end our discussion of nervous system disorders with spina bifida, which is a developmental anomaly as a result of a defective closure of the encasement of the spinal cord, so the neural tube. And as a result, the spinal cord and meninges may or may not protrude. We do know that certain environmental factors and genetics play a role in development of this, yet 50% of them are completely idiopathic. We will see a higher incidence of them in women who contract rubella while pregnant or are taking anticonvulsive drugs. Chromosomal abnormalities have also been implicated, as well as a deficiency in folic acid. Clinical manifestations are variable. They can have spina bifida occulta, and this is where the anomaly is not visible. Simply the posterior vertebral laminae, they haven't fused. So it's very common. Up to 25% of infants can have this. It just shows up as changes in the skin and the body hair, and so they can have a little port wine angioma or lymphoma or even a little dermoid cyst. They have no serious problems. However, some may have a little bit of disturbances in the gait of their feet or their bladder. Spina bifida cystica, however, has an external protrusion. This is filled with cerebrospinal fluid, but it does not involve the spinal cord. They, however, can suffer permanent neurologic damage, and so they can have motor weakness or paralysis, sensory deficits below the level of the spinal defect. They can have bowel and bladder dysfunction, scoliosis, hydrocephalus, and seizures, and this will worsen as they age. So you can see treatment is based on the severity of the defect, and you try to prevent it by giving folic acid. And here's one picture of it, and we'll see better picture in the next slide. And these are actual pictures of the spina bifida. And poor little guy, especially the little guy on the left, is so cute. But this is the end of our discussion then on disorders of the neurologic system. Next week is week 15, and our final tour de force, if you will be in the musculoskeletal system. So study well, and I'll talk to you for the last time next week.